Hey, welcome back. In the year following giving birth, or even longer in some instances, South African women who feel depressed or anxious may be in danger of dying by suicide or occasionally attacking their own children. However, poorer women are less likely to receive the mental health care they require. To discuss this further, I'm joined now by the Director of Perinatal Mental Health Project at the University of Cape Town. That's Dr. Simone Honikman, who joins me now for that conversation. Dr. Honikman, thank you for your time. So you will realize there that even the terminology and getting these things right continues to be something that we continue to navigate as people in South Africa. Just tell me about the incidence and the depth of the problem of postpartum depression in South Africa. There's a recent study that was done that you've been quite involved with. What does it tell us about the dimensions of the problem we're dealing with?
Well, I think it's helpful to look at depression together with anxiety. They often go together in the perinatal period. So when we speak about the perinatal period, we're speaking about that whole time during pregnancy, from conception to birth, and then that first year after the birth of the child. And it appears there have been a range of studies across South Africa looking at prevalence, or how common depression is and how common anxiety is. In fact, there have been more studies that have looked at depression. And there have been a wide range of results, from 1 in 10 women to 1 in 2 women in this period experiencing depression. I think it really depends on the group of women that have been sampled, and particularly looking at the kind of tools that were used in this research to identify or to screen for the disorder, for depression.
Yeah.
In studies that I've conducted, we found that about 1 in 5 women, about 22% of women had depression using a diagnostic measure, and about the same amount had anxiety using a diagnostic measure, which is a much better tool when one's looking for a true valid rate of these conditions.
Yeah. So this latest study that we are talking about and some of the dimensions that are coming to the fore now talk to the socio-economic conditions and the difference in access to health care, particularly in the South African context. What comes up when we look at those dynamics of, who is likely to suffer through a period of postpartum depression and anxiety, but still not have the requisite access to the healthcare that they need?
Absolutely. A lot of the high prevalence that we're looking at is directly linked to social and economic factors. So while these conditions can affect women across the spectrum, women who are experiencing hunger, food insecurity, other forms of poverty, women who are experiencing violence, women who are HIV positive, women who've had trauma in their past, women who are socially isolated and don't have a supportive family or a supportive partner. These are women who are at much greater risk than other women. It's not to say other women won't have these conditions. We're just looking at risk profiles. Other high-risk groups are adolescent girls, women who are displaced, or foreign nationals coming from extreme conditions of civil conflict or wartime areas. So people who've experienced trauma, either in their past or experiencing a chronic traumatic environment, and who are isolated and don't have social resources and to support them, are at much higher risk. And these are the women, the very same women, who have the least access to care in our system. And we're working very, very hard to change that. There is a new policy, a new maternal, neonatal and perinatal policy that was ratified mid-21. And we're working right now to develop the national guidelines so that we can translate this policy into real implementation on the ground.
In fact, I'd like you to talk to me a bit more about that because, my sense is, and you'll correct me if I'm wrong, Dr. Honikman, my sense is that in the period, during the pregnancy, the focus is on health as in the sense in which we've always defined, is the mother healthy? Is the baby healthy, developing properly, all those scans? I don't know, you'll correct me if I'm wrong, I don't know if there's any focus on what is the mental health of the mother. And post that, childbirth being such a huge life event that it is, the focus tends to be on, is the child developing safely? Are they getting their inoculations? Nothing that talks to the focus. So is there anything that can be done at a policy level that says, actually when the mother and child go for those checkups, this should be integral in what we do?
Absolutely. There is no health without mental health. And you spot on, the focus has been on the physical well-being, on survival, on physical disorders and preventing them or treating them, survival of the mother and survival of the infant. There has been, up until recently, very little appreciation about how mental well-being affects physical outcomes. The two are intimately linked to each other. So a woman who is depressed or anxious is less likely to be able to use maternity services, finds it greater challenge to adhere to antiretroviral treatment for HIV and all sorts of other health treatments and processes that we're expecting women to do. So depression really, and anxiety really impacts how people use available services and impacts people's physical health. So we need to integrate mental health into physical health care, and it can be done and it should be done. It's done in many places in the world. And the brand new policy from that I mentioned, that was signed off at the beginning of last year, now places mental health as one of the top key life-saving, acknowledges that mental health care is one of the top key life-saving interventions that we can do in the maternal and neonatal health system.
Yeah.
So we do have a screening tool in the maternity stationery. We need to ensure that the screening is implemented well and that there are referral pathways so that when women are accessing maternity care for their physical health and the health of their infants, they're at the same time, in a one-stop shop fashion, able to receive mental health care so that it's an integrated and seamless service.
Is there anything further, Doc, before I let you go? Because some of the manifestations of what we're talking about take the form of death by suicide. Is there anything by way of intervention there that could be, putting out that fire that says, how do we, while we talk about the broader policy pivot that needs to happen, how do we address that particular aspect? Because I saw one of the statistics talks about 10% of women who have a mental health issue problem postnatal, in the postnatal period, are likely to die by suicide.
There's work that can be done by the health sector. There's work that can be done by the social development sector, and there is a lot that can be done in our communities to prevent suicide. We don't have a good handle on the rates of maternal suicide because of poor reporting mechanisms and because of the stigma of reporting death by suicide. So we don't really have a good idea of the rate. It's likely to be very high. Suicide is a leading cause of death in high-income countries, of maternal death. What we do know when we do audit some of these deaths is that almost always there are signs way back during pregnancy that women are in distress and women are not coping. There are ways in which, if we look for it, if we open up the service to include a respectful and careful and compassionate inquiry into how a woman is coping emotionally, and we look for some risk factors, has there been a previous attempt to harm oneself, then we may well be able to prevent self-harm. We may be able to hook women into supportive services. I think it's also critical to realize that women may harm themselves even if they don't have a mental health problem. So whereas self-harm and suicide may be related to mental health problems and particular depression, it's not necessarily linked to depression. And some women have very strong suicidal thoughts or behaviors, and they may in fact not be depressed.
Yeah. All right, I've got to thank you for your time and your insights here on ENCA. It's a truly important conversation, and I don't think we get enough of it. That is the Director of Perinatal Mental Health Project at the University of Cape Town, Dr. Simone Honikman.